So, hi again. Let's get seated, and we're going to start our last two speakers, and I think you'll really be excited about them, as I am. And let's see if I can get the pronunciation right. Dr. Prabhjot Singh his work has been heavily influenced by his clinical role as a physician and community activist in Harlem, New York. He's an assistant professor of international and public affairs at Columbia University and director of systems design at the Earth Institute. Dr. Singh is also the chair of the 1 Million Community Health Workers campaign, which is hosted by the African Union and the United Nations Sustainable Development Solutions Network. Domestically, Dr. Singh is the lead advisor for City Health Works, where he applies lessons learned from his work abroad on financing, scalable systems, and workforce management to community health challenges. He's a member of Mayor Bill de Blasio's Advisory Council on Child Well-Being, a member of Huffington Post's Medical Review Board, one of 10 Robert Wood Johnson Foundation's Young Leaders, a Paul and Daisy Soros New American Fellow, and a 2013 Pop Tech Science Fellow. That's a lot of fellowships, wow. His wife, Manmeet Kaur, has been a national and international champion for healthier communities and equitable livelihoods for the past 10 years. She's the founder and executive director of City Health Works, a not-for-profit social enterprise based in Harlem, New York, that supports reverse innovation in healthcare by applying lower healthcare systems. Let me read that again. By applying lower-cost health systems implemented in developing countries to domestic health. CORE has also worked in New York City to improve the working conditions of unregulated workers with LaborNet, a social enterprise in India that stabilizes the chaotic lives of construction day laborers, and with Mamelani Projects, a South African program that helps HIV-positive individuals build their own health food business. Before launching City Health Works, CORE was an advisor to the Earth Institute's strategy on the retention and financing of community health workers in the Millennium Villages Project, which has contributed to the 1 Million Community Health Workers campaign across sub-Saharan Africa. Thank you, Dr. Singh and Manmeet.
Well, thanks so much. It's really a pleasure to be here, and we're so honored to be hosted by the Colorado State Health Foundation. When we came here a couple of days ago, I mentioned to Manmeet that people are just so friendly here, and it was amazing to just see that it seems like people that really know each other in a way that kind of was immediately notable. And it really speaks to a really great community to do this sort of work together. So we're husband and wife. You can hear from our bios our work intertwines, and so is our presentation. It'll kind of seamlessly move back and forth, and it's going to be a bit of a medley. And I hope that it'll be a little bit refreshing. You'll hear things that are perhaps seem a bit out in left field, and then we'll try to bring it home by the end. We'll see if it works out. Okay? So, in 1963, I'm going to throw it way back before I was born, Kenneth Arrow, a Nobel Prize-winning economist, wrote a seminal paper that started the field of health economics called Uncertainty and the Uncertainty and the Healthcare Economics of Welfare. And in it, he has this section when he says that if we transfer the purchasing power from the well to the ill, then over time prices will increase, and over a larger amount of time, the amount of medical services supplied will increase. And 50 years later, next year is 2015, 50th anniversary of Medicare and Medicaid, we've had 50 years of investment into the medical care and services industry, and it's yielded kind of gangbuster in terms of returns, $2.7 trillion industry. And yet, we know from all the talks before and the whole theme of this symposium that medical care itself comprises a small part and an important part of what it means to be healthy. And we are at a point where we are actively talking about how to make a switch into a new era. And it can become so hard to imagine what it is like to build a system for that other part of health, that majority part of doing the things that are for health and not just medical care, that we can't even imagine what it would be like to start 50 years ago and build it up again. And so if we could have the slides. What we're going to do is kind of cleanse your palate, your mental palate, and I want to take you to a place where I grew up. I grew up in Kenya and across sub-Saharan Africa in work that starts out in a very different premise. You have almost equal footing medical systems and non-clinical systems for healthcare. And over the last 15 years, there's been a massive rise in investment, but one that has not followed the same course as what we've had in America. And so the type of systems that are being built across sub-Saharan Africa look and feel very different, and to me, seem quite relevant to the challenge that we have here across the country. So just step back for a second, kind of forget Colorado, forget America, and look at this map of sub-Saharan Africa. On the right, you see a heat map, and it shows the distance to market, where you'd probably find a clinic or a hospital. How long does it take to walk there? Aside from the big red area, which is the Sahara, and then you see the Sahel, you see that across most of that map, there's a lot of red, yellow, and green areas, which mean that it takes over 2 hours to get to a market. Even though Africa is rapidly changing, it's booming in terms of economic development in certain areas, when you go across most of the continent, you still have the same scenario where the entire logic of taking care of people is flipped. You don't start with the premise of a clinic or a hospital. You start with the premise of where people live. It's the only way to actually build systems sensibly. Otherwise, you'll be putting things, clinics and hospitals, in dots that are hours and hours away from people and ultimately inconvenient to the majority of the population. So that's the basic premise. It's almost a place-based approach is built into the DNA of these systems. In this context, there's been a massive investment in addressing basic illnesses that kill children under 5 and in maternal mortality. These are issues that seem really distant from us in the US. We're talking about diarrhea that kills kids. We're talking about malaria that kills kids, pneumonia, and so forth, in huge numbers. And in some basic way, you absolutely need the medical system, and yet you cannot get the medical system and get the people to just file into the clinics, into the hospitals. People just will die along the way, whether that's for mothers or children. And so we've had to really rethink the whole premise of how we actually deliver care. There aren't enough doctors across sub-Saharan Africa. It turns out there's probably going to be a doctor shortage, at least as advertised in the US. But in sub-Saharan Africa, it's fairly stark, unless you're talking about parts of South Africa and kind of urban centers. And what we've discovered is that community health workers, people that are rapidly trained in neighborhoods, taught basic protocols, fairly simple ones like as follows: if a child has a fever and they're under 5, give them a rapid diagnostic test on the spot. If it's positive, give them Coartem, an anti-malarial. If it's negative, see if their heart rate, their breathing rate is above 40. If that's above 40, give them amoxicillin for pneumonia. If none of those, get them to a clinic. And it's those sort of simple protocols, you know, if we just repeated that exercise 5 times, you'd have gotten it, that you can actually train people to do this. You can give them full-time jobs. You can equip them with technologies that allow this system to be well-tracked, to have performance improved over time. And ultimately, what they do, the magic of what they do, isn't necessarily in the giving of the pill or getting a woman to a facility. It's having all the interactions at the household in a community setting that really begin to explain what this is all about, negotiate different people's beliefs about where is the right place to give birth, and to ultimately have a conversation about health and well-being that actually travels backwards to people that make decisions to help them redesign and reshape the systems that they're delivering. And to me, that degree of feedback is so important. When was the last time you heard that community engagement actually changed the entire program and design of the healthcare system as it emanates outwards? That it changed the approach of how people actually built protocols, did design, build the technologies that our yesterday's speaker spoke about, the wonderful world ahead. And so that's, to me, an important feedback loop. How flexible are these two worlds in relationship to each other? And that's a conversation about people, about economic power, and about political responsiveness. So here we have a system where we know that community health workers can reduce maternal mortality and child mortality by 25%. Just lay workers, trained over time. But they need systems, and they need investment, and they need support. This is basically what I mentioned. A person goes to a household, but what they carry is a mobile phone that allows them, like Foursquare, to check in where they are, allows people to learn about how they're working in environments. They can call for decision support. They have two lines of support, clinical supervision, and they have people that are looking out for how they're actually doing, workforce supervision. And they're also responsible not to just a clinical system, but to a local governance structure. And this tension is in play that keeps people both doing things that are absolutely critical and important for the medical system, but also not so sucked into that world that they lose context and their own sense of who they're responsible to ultimately. So from our perspective in this work we've done, community health workers are not just a link in the delivery system, in the delivery of health services. They're ambassadors. They connect two different worlds, and they require investment, and they require support beyond, I believe, stipends or just extra kind of support that they're doing a good job. They really do need thinking about them as an independent system that is interdependent upon multiple worlds. What we've been able to do with that investment is create systems that satisfy both worlds. We have ways that we're creating employment. We're getting feedback from communities and redesigning our systems. And at the same time, those people that run hospitals and clinics that are investing money into these systems are able to track data in real time, provide feedback, and look for trouble spots amongst places where people are not doing as well. We're able to do things that are kind of like community-based management rounds. You've probably seen graphs like this if you work in a hospital everywhere, if you work in public health, just dashboards, scorecards, and you can end up building things that are ultimately not just so high level. People understand what they mean, that things are either going well or not, and they can start looking for and sourcing solutions. Ultimately, what we've been able to build is a system that is about community-led goal setting and discovery. It's been invested in because they're solving critical medical problems and they're addressing some things that are urgently needed. But at the same time, it's a sensor network, it's a feedback system that allows people to actually find out new problems that you did not anticipate and that may actually be even more important to the community than what you're offering them. And that conversation and that alignment allows for building these systems kind of coterminously in a way that we haven't really seen. And so it's in this context that we've built the 1 Million Community Health Worker campaign, which is right now operating across 15 countries, to scale up these systems. And it basically works by giving planning support. We work on management and improvement of the workforce itself. We help on making sure that there's some degree of balance between clinical needs and community needs. And that's a fairly complex, long process of just discussion and making sure that we're always realigned. We make sure that we're actually hitting objective coverage targets and that things are going well over time. And so it's in this way that you see investment from political leadership, from communities themselves into rural jobs, into ways of building expertise and skills. And on the other hand, you see investment from the medical and healthcare communities because they're also solving problems that are important. Okay, so palate cleansing over. What can we take from this system back to the US? And I'll tell you, as I was going through this work, I was actually in residency. And I was doing internal medicine training in New York, in Harlem. And I thought about this all the time. What is it that we can bring back from what we've been doing abroad back to our systems here? And I'm going to give you 6 principles that we've seen that seem to make sense to us and form the kind of basic principles of what Manmeet will talk about in her approach to building City HealthWorks. The first is that we need to build close-to-client, location-based services. There's so many ways to say this. We can call it place-based. We can call it community-engaged. We can call it moving outside of the clinic walls. But the point being that you actually need to get out to where people are, because otherwise you will not understand the context of what they're doing, how they're doing, and ways to improve it. Second is that actually protocol-guided activities are really important. They're important. They end up building the core of an industry that is now this 2.7 trillion industry. And they're also the core of doing things in communities. Now, you may say to yourself, are you talking about having a checklist for how do we interact with the community? But I've seen checklists for community organizing. I've seen checklists for engagement. I've seen protocols that help people kind of get up on the scaffold of being better and better what they do at engaging the people that they're working with. Third is that we actually do need strong primary care and emergency service integration. We talk about these worlds of downstream and upstream like they don't coexist. They coexist all the time. The same person in a family that needs support and encouragement to be healthier is next to somebody who also is very sick. That person may be a caregiver to that person, to the person that's sick. And so having the ability to have this close touch and integration is critically important. And at the same time, creating linkage with all the community-based organizations, services that are out there. And now this sounds almost pie in the sky. How are we going to go about doing this kind of massive integration without building some kind of draconian policies? The fifth area is real-time feedback. We don't often demand or expect that from people that we're working in the field, that are at the community level. We don't always demand that they have the same touch on information, the same sophistication that you'd expect in the settings, in the healthcare settings. But these are very important. And then finally, it's always important to think about scaling up and sustainability. It doesn't mean that everything has to get big. But it does mean that you're constantly engaging with people that are at the spigots of economic power or having discussions with people that are making political decisions. Talking about scale and sustainability isn't just about going big. It's about being in conversation with decision makers and making sure that you're part of those conversations along the way. So I'll just pass it off to them and meet.
Thank you again for having us here. I wanted to also add that along the way of building City HealthWorks, I looked to the work of my co-panelists specifically for inspiration and to learn a lot along the way of creating this. So it's really a privilege to be part of this panel. So when I met Prabhjot 6 years ago, I never thought I'd ever be working in the US healthcare system. I grew up in Queens in New York, and I began my career very passionate about immigrant rights issues and then labor issues. And I had the fortune of being able to go work abroad for a couple of years after college. And I had always wanted to go spend time outside the US. And it was actually working abroad that made me very excited about opportunity to do really interesting things here in the US healthcare system. And so as I started thinking about this idea, and at that time Prabhjot had started residency, I was really struck by the way in which people cycle in and out of the healthcare system. And where we live in Harlem and where he was treating patients, I would ask him, what happens when you treat someone or diagnose someone with diabetes for the first time, or if they come in with a condition that they're struggling with amidst far more serious concerns in their life, whether it's jobs or housing. And I'd look at him and he would respond and explain what would happen in that 10-minute interaction, and I'd wonder, was he a careless physician or was he part of a careless system? And as a non-clinician, I was really quite baffled. From my experience building community-based systems in New York City and South Africa, where I worked beforehand, I felt that there was quite a serious missing layer to our healthcare system here as I began to learn more and explore and have further conversations with people in our neighborhood and other clinicians and community members. And I thought that in particular there was a gap in helping people achieve better health because conditions like diabetes require significant lifestyle changes that are particularly difficult for anybody of any income level, and behavior changes are complicated. They also involve socioeconomic factors that, as we all know in this room, have a far greater influence on people's ability to achieve better health. And in a neighborhood like East Harlem, which has the highest rate of diet-related diseases in New York City, and also an average income of $17,000 a year, these factors, these non-healthcare factors, certainly weigh a lot more heavily on the lives of the patients coming through his door. And so I started thinking back to the work I'd been doing, and particularly in South Africa, with peer health educators, and thought about the power that peers could have in influencing behavior change, but also in helping people in neighborhoods like this navigate this very formidable healthcare system. When I first met Hilda, who is one of our health coaches now at City HealthWorks, she talked about how she had cared for her grandmother who had died of diabetes-related complications. And she had, at the time, when she looked at this job description for a health coach, could not believe that she would be paid to do a job like this, because she, just like every one of the other health coaches that we've hired, or anyone who expressed interest in this job, was doing that already, either for their family members or their neighbors or their dependents, but they have seen the effects of this silent killer throughout their neighborhood for quite a long time. And so I knew that if we built an organization that invested in the natural skill set, the natural listening abilities, the deep knowledge about the neighborhood that people like Hilda and Lenny had, we could create quite a powerful influence on both helping individuals improve their health, but also addressing this gap between health and healthcare. So I essentially started by building a workforce development organization, which is how I sometimes consider City HealthWorks, that hires, trains, and professionally supervises a network of community health workers who we call coaches, to serve as a bridge between the doctor's office and the real challenges people face in their health. As I started building City HealthWorks, I was fortunate to meet Danya Williams, who's our Director of Operations now. Danya had led the city's Healthy Bodega initiative for 5 years in New York City, an initiative that many of you are familiar with in many parts of the country to increase access to healthy foods. She realized over that time that access to healthy food wasn't enough to change behavior, to convince the bodega owners or grocery store owners to put more and more vegetables up front, and that in addition to access, you really have to engage people individually. So I envisioned an organization that would sit at this intersection of health and the neighborhood, and that would hire people from the neighborhood to serve as health coaches. And they would essentially be able to meet someone either in the doctor's office and be introduced at that point of care to continue coaching and meeting them in the home or neighborhood setting. Or they'd be able to engage people by knocking on doors because of their rich knowledge of the social fabric of their neighborhood to try to get those people who are not yet at the hospital's door. So both proactive care as well as preventative. And so we went forward with creating this organization that mostly focuses on building the deep skills and confidence of coaches like Hilda. And so today what our team of health coaches who are clinically supervised actually do is that they meet individually with people who are diagnosed with chronic diseases like diabetes, hypertension, asthma, or who are at risk of developing, who are pre-diabetic or at risk of developing chronic illnesses, to provide one-on-one coaching that's grounded in motivational interviewing techniques and skills. And the whole idea is to just meet people where they're at and gradually get them to achieve very small goals. Because if we get them to achieve one, the ripple effect is powerful on not just their health, but other parts of their life. And from the very beginning of this interaction, with the role of a clinical supervisor, we actually engaged their primary care provider for input on what they advise the goals of this engagement to be. Along the way, we also identify who lives in the home environment with our clients, whether it's home aides or family members or dependents or neighbors, who we can engage to say, after Hilda or Lenny reduce their time and engagement of coaching, we're identifying people who we train and strengthen their role in the household environment to make sure that these changes and goals are long-term beyond the course of the year. And we've also trained our team on behavioral activation therapy and methods for addressing mental health, which we anticipated being a major need, and now that we've actually started delivering services, we are moving towards investing in a lot more heavily because of just the tremendous rate of comorbid mild moderate depression. And then, very importantly, we also connect our clients to trusted social services, whether it's jobs, housing, or other services. And so at the heart of our organization and our approach, and this is how we would approach it in any environment after demonstrating its value in Harlem, is a set of coaches who are supervised by a clinical care manager. This clinical care manager is a critical link and bridge to the clinics across the neighborhood. So we've built relationships across the zip code with now 3 clinics who are operational and 4 who are in our pipeline, with whom we actually are part of the medical record system and can see and communicate with providers in real time about medical needs and ensure that medical issues that we detect early get seen sooner. And on the coaching, and related to that, I would say that the coaches, in a sense, are disrupting that relationship a bit between the providers and their patients. They're teaching their doctors of our clients a lot of things like the patient never told you they didn't understand what you were prescribing because they couldn't read, even though they waved their head very politely, or they just were too embarrassed to say that they couldn't afford the medicines. And so we're repeatedly having these situations where the doctors are re-evaluating how they are treating patients based upon what they're learning from the coaches. More importantly, the coaches are, as they are from this neighborhood, they're incredible asset is their ability to understand what myths people think of, have about diabetes in the neighborhood. What are the fears that people have that are preventing them from ever getting to the doctor's office, and addressing those based upon their common shared experience of living in the neighborhood and their shared experience of knowing who to trust and where to go for the support that they need at the right time. So over the past under a year of operations, we now have about 100 active clients, many of whom have graduated from the main part of the interventions or active stage of the program, although this is a relationship with a coach that's lifelong. We've seen amongst the first 20 patients reductions of 0.5 to 1.5 on their A1C levels or blood sugar levels, and between 6 to 10 pounds of weight loss of our first 20 clients. And amongst the first 100, we've estimated that we've saved over 17 emergency room visits, which is truly attributed to this robust linkage between clinic and neighborhood in a way where you have coaches who are really the eyes and ears of what's happening, and that's communicated in a way that's very direct, immediate, and relevant to the healthcare system. As we started the organization, we began by engaging the clinics and health systems in East Harlem, and also a set of funders who believed in this vision, who would seed this organization. But the mission since the beginning has been to figure out how to ensure that this is a financially sustainable approach that's also scalable, which Prabhjot will speak a bit more about shortly. On the financial side, on the clinic side, we have operationalized 3 very significant clinic contracts and relationships with Mount Sinai Hospital Center and 2 federally qualified health centers in Harlem, and with 4 others in our pipeline. The Robert Johnson Foundation and Robin were our first key seed donors, and we also have 10% of our revenue right now actually from a patient-centered medical home contract with Mount Sinai, who had dedicated funds to us in order to help them achieve those outcomes with their patients with diabetes and hypertension. We are now joined with 2 subcontracts, CMMI subcontracts, as well as baseline funding from the City of New York, who is very invested in building infrastructure that supports community health workers, not just to address those health outcomes that the healthcare system cares so much about, but also to ensure that we can continue generating value around the support and the activities that we do to address those psychosocial factors and those socioeconomic factors that shape health. And so in terms of that payment model, we've also been engaging health insurers, particularly Health First, Emblem Health, and others in the New York area, on determining what would be the to evaluate the return on investment, and then to develop what would be an appropriate payment model for this down the road over the next couple of years. I often think of my team of coaches and staff as my board of directors, and every week we have team discussions about what are we learning and what can we improve. And some of the key challenges that we have been working really intensely on, how to improve our way of communicating, motivating, and engaging low literacy or no literacy clients, which we've been surprised by the degree of which we've had in our neighborhood. And also how to become even more well-trained and skilled and capable as coaches, as lay health workers, to address trauma and mental health, as that has become far more of an issue that we had always planned for, but an incredible amount of trauma coming up very early, and I think it has a lot to do with meeting with someone who is from your community but can also talk to you about your health. And then, of course, financial challenges of our clients. But we're also very positive and excited with the number of people in the neighborhood who are just so excited to have the potential opportunity to also have this, to be a health coach. So I'm going to pass it on.
So, I think some of the main questions that we have are, there's an element of doing this sort of work where you have to have trusted relationships, you have to build within an area, and you have to be some degree a known entity and then start building from there. So the question is, for us, how do you end up doing this in other locations? How do you end up scaling up not only the financial infrastructure, which is in some ways a little bit easier as we're starting to see, and we can get into more detail about that, but also how do you end up scaling up or transferring or replicating the collaborative infrastructure? We have built in kind of a somewhat orderly fashion a way that we start reaching out to community-based organizations first, and then kind of moving back to the clinics, and then going to politicians in the neighborhood, and then going to insurers, and then moving to other outside actors that once we've established a good sense of relationship inside that community. And so we're really thinking, especially as I begin to work with the Institute for Health Improvement and RWJF on kind of much larger healthy community initiatives, how do you end up kind of building this scaffold for collaboration that allows for a lot of different types of things that come out of it? One of them may be community health workers. How can we do that more and more quickly or more rapidly in a way that people can anticipate it, they know what their role might be, and how they can interact in that environment? And so that ends up being kind of one bucket of questions that we are starting to work on and starting to move into other neighborhoods to begin thinking about how to assemble that more and more rapidly. The second type of question ends up being around the payment for the community health workers and City Health Works. We really take what I would call a portfolio approach. We really are not looking for, even though you saw a lot about the healthcare system has to be a share and have a stake in City Health Works, but the moment that the share gets too high, we're going to be chasing only HEDIS scores and 5-star ratings for Medicare, Medicaid, and so forth, which are part of our portfolio. But creating that balance between making sure that we're actually still serving the community, and what I mean by that are starting to do things that are, first of all, just being present and participating. Even if we don't always think that massive health fairs are very high yield, it's very important for us to be present at them and to make sure that we are part of that environment. At the same time, it's very important to not just wait till the patients have a diagnosis. And we have that ability to do so through the relationships we're creating in our social networks across buildings. And there's interesting ways that we're starting to do that, but that requires its own investment kind of area. And that's coming not only from the city, but interestingly enough, from real estate itself, from work with community development corporations and CDFIs. And coming up the pike, we have a lot of interest from the impact investment community, which has had kind of an early start on working on things like social impact bonds, but recognizes that they have to be potentially more flexible and built in different ways in order for them to be more applicable to all these different settings that we're talking about. And so I think the takeaway from us is that we really, and it may be an odd thing to say, but we really are careful about choosing our funding sources in the sense that funding sources themselves in many ways end up describing what your organization will do. And the odd thing is that when you start saying that you're choosing your funding sources, funders seem to be more interested because there seems to be some recognition that there's some discernment about mission, goal, and understanding what you're trying to do. And at the same time, building a collaborative framework between your funders and other funders that are out there. And that's been a very interesting set of discussions that we've begun to introduce and broker that would never have happened had we had just kind of piled on in with one approach and tried to grow as fast as possible. So in short, we are modestly small here. our goal is to make sure that we don't grow too fast so that we have too much kind of philanthropic raise to deal with every year. And at the same time are kind of making it as quickly as possible towards our financial sustainability goals. One of the most exciting things on our agenda has been work with United Healthcare Group on working with their actuarial team. And it's basically, we've been looking for actuaries. We've been looking around other insurance companies, and there's a few now that have come forward that are working with us on this specific question. The question that they're interested in is, if you have two people that have to hit the same clinical goal, but their life circumstances means that one is just going to be much harder than another to get there, can we start to predict the effort that we're going to have to put into these two different people? And that means understanding those two different people in very different ways, systematizing your understanding of all these contextual factors that all of our speakers have spoken about. And can we start to do some ability to predict and start to help give people some sense of what it'll take to address those groups? Because in some ways they have to address those groups, period. And the question becomes how and how much effort can we predict it, can we anticipate it, and can you and other groups like you help us do that? And so I think what we've really seen is such a huge interest in not only the kind of analytic infrastructure. We can now look for high-risk patients. We know communities that are higher risk. We know places that are not at high risk, but they can go much further. They have much further to go in terms of their health and well-being. But can we do some ability to predict how much effort it's going to take to get there? And that is the kind of specific question that we end up taking on when we go to groups that are looking for how to price our services and how to price community health workers and build a financial model behind them. And so, we are kind of in a messy open stage at the moment. Lots of open conversations with probably 5 to 10 different types, entirely different areas and types of funders. But at the same time, trying to pull down what seems to be kind of a rational way to maintain the character of community health workers as being community anchored, and at the same time allowing us to pull in from this $2.7 trillion industry some of that energy and expertise, as well as economic power in order to build this and make it grow. And so, with that, I think that's, I'll just add this last slide, which is just to say that, when we look at City HealthWorks, it's to us a seed. In it are components of workforce development, and that is an entire universe unto itself. There are people that are interested in City HealthWorks because they see it as STEM training. They see it as science and technology training. They're learning how to use mobile phones. They're learning a little bit about healthcare. It's also intensive home-based coaching, which has a completely different kind of arena of engagement. Same thing for primary care integration, which is a world unto itself, and we work with ACOs and PCMH programs and kind of larger programs and understanding how we fit into larger population health management infrastructure. We're also embedded in the neighborhood, which frankly takes us the most time. It's where FaceTime matters the most. It's where maintaining relationships matters the most. And the moment you're seen as just another extension of one of the major healthcare systems, you lose your identity very quickly. And it's something that we've seen with services over and over again in our neighborhood. So maintaining that balance is always a challenge. And then finally, we actually see financial sustainability as part of one of our outgrowths, our missions. So we intend to grow in a way that may be replicating City HealthWorks in other places, but ultimately we want to make sure that we can open source our infrastructure, how we do contracts, how we built our operational machinery, so that people in other states and cities can start to play with this infrastructure and see how they can put it together themselves. So building those building blocks is something that's very important to us as it starts to come out of City HealthWorks. And so with that, thanks so much.